Thank you. Hello, everybody. Welcome to the School of Health and Society's December Research Seminar Series. Very special edition today. We've actually got some of our recent postgraduate completers coming to talk about their dissertation projects. Just before we go any further, can I ask if anyone who's not speaking can just put their self onto mute? I'm just getting a little bit of feedback. So each speaker today is going to be talking for 15 minutes, and we're going to be starting today with Funmi Oyediran. Now, Funmi is an international pharmacist who's recently attained a master's degree in health and social care right here at the School of Health and Society. She'll be graduating with a distinction. Funmi's journey is not only marked by her academic achievement, but also by her contributions, serving as a student ambassador within the school, to the student community here at the university. Funmi was a key contributor to the design and launch of the school's common room and also the course rep for the MSc programme. Beyond her academic and leadership roles, Funmi is a member of the National Association for Care and Support Workers in the UK, showcasing her commitment to staying informed engagement in her field. Looking ahead, Funmi's passion for academic exploration drives her aspiration to pursue doctoral studies. She seeks collaboration with interested lecturers and organisations devoted to advancing social care research, particularly in the critical realm of mental health. Funmi, I'm going to hand over to you. When you're ready, please start. Thank you.
Thank you very much, Chris. Okay, I hope everyone can see my slides. I'm not very good when it comes to sharing on Zoom, but thank you very much, Chris. Thank you, my lecturers and my fellow students. And I am very honored to be here. I'm glad I accepted this invitation, and thank you to all our lecturers who ensured that I was able to finish with a distinction. You will pardon me ahead of time. I recently lost my dad just a few days ago, and because he would have been proud to be right here on this program. However, he departed happy that I did graduate with a distinction. So moving on, the title is Exploring Approaches to Mitigate Stigma Surrounding Mental Health Illness in the Elderly, a comprehensive literature review. The objective for this dissertation included the analyzing of existing literature and the discussion of strategies using the labeling theory framework to analyze and critically evaluate it. All of this was in order to help us understand the multifaceted nature of mental health stigma in older adults. Now, the methods, the results, and the conclusion will be extensively discussed as we proceed with this presentation. Stigma, according to Goffman, is a deeply discrediting trait that usually transforms individuals who are affected from being whole and feeling well and feeling normal to feeling like stained, discounted individuals. That was in 1963. Now, in 2001, Link and Phelan did add to Goffman's description and said that the three points of status loss, discrimination, and emotional reactivity all have to be in place before stigma is totally complete. However, Vargas, Folker, and Anderson did expound on it further and said that stigma is always present wherever there are negative labels, wherever there are unfavorable stereotypes, wherever there is language segregation, and wherever there are power imbalances. So the presence of these four conditions unequivocally mean that stigma is present. According to the WHO in 2017, the percentage of elderly individuals over the age of 60 who are mentally ill will nearly double from 12% to 22% between 2015, that's about 8 years ago, to 2050, about 28 years from now. Ageism, misconceptions about older individuals' mental health, generational or cultural attitudes towards seeking for mental help, all of them add to the stigma that older people with mental illness endure, because it is believed to be a kind of double stigma. One, you are elderly, And then 2, you've got mental health. So it's like a double burden that the elderly carry. The central research question for this dissertation was, what are the most effective strategies for reducing stigma among the elderly living with mental illness? And the secondary research question was to discuss the effectiveness of these interventions. Giving us all a very brief background of mental health illness, historically, mental health illness was seen to be influenced by mystical beliefs or magic or fears or cultural norms. In the Middle Ages, a number of people were excluded from normal society. They were perceived as being either witches or being mad. And as time progressed into Renaissance and into the modern era, gradually asylums were being built, and all of these did contribute to more stigmatization. However, in recent years, even though there's been a lot of medical and psychological advancements, a lot of campaigns, there is still stigmatization. And wherever you find stigmatization involving the elderly, it does affect them whether they are well, like I said, because if you are well as an elderly but you are old, then you may face ageism, which is also a form of stigma, and it does affect families. The COVID-19 pandemic also highlighted social stigma around mental illness in the elderly, even though there was also mental illness in all age groups. But because this dissertation focuses on the elderly, it therefore emphasizes the need to address and combat this issue. Now, the rationale behind this dissertation lay in its acknowledgement of a critical social and healthcare issue. Because stigma around mental illness is widespread, its effects on the elderly population are alarming because the elderly grow every day. Everyone gets older every day. So the population of increasing elderly is more than it was, say, 10 years ago. So because of the increase in age due to increase in long life or longevity of life due to technological advancements and other benefits that help the elderly, all of this has brought about more problems affecting the elderly. So this particular dissertation focused on the elderly because, according to authors like Bering, Suvara, and Bambura, they do assert that a broad range of health groups or age groups do exhibit the tendency to stigmatize generally, but there is a lack of specific primary research focusing on the elderly. So this contributed to the rationale for this dissertation. The methodology, using EBSCOhost, I began my search strategy using the PO grid as the population, exposure, and outcome grid. Now, under the population table, I used search words elderly, aged, older, elder, geriatric. Under the E for exposure, I used stigma, prejudice, attitude, discrimination. And under the outcome, the O, I used mental health, mental illness, mental disorder, psychiatric illness. Now, using the Boolean operators O and, I was able to eventually get 121 results. And this results covered a number of countries. It focused on the UK and the US, but there were additional insights from Canada, Singapore, Hong Kong, Denmark, and Poland. The search strategy was also supported with material from the University of Wolverhampton Library Search Catalog, as well as the Google Scholar Advanced Search. In addition to the search terms, search words of elderly, aged, older, elder, geriatric, search words like reducing, stigmatization were also included as well. This research dissertation adopted an inclusive approach because, in acknowledgement of the gap and the justification for the rationale in relation to the lack of exclusive primary research studies strictly focusing on the elderly, therefore, the research had to include primary research articles which focused on both the elderly in addition to younger age groups. However, The information was extrapolative to the elderly population, and it was justified every single step of the way. The key findings for this research dissertation were a discussion of 10 patterns or themes. The research employed a thematic analysis, and the results include these 10 findings. Support and connection, which could be social, which could be IT, which could be otherwise. All of these findings were evaluated in relation to the labeling theory framework. And all of these studies do show the importance of labeling theory. Because according to Goffman, who claimed that stigma is a widespread aspect of social life, which makes simple everyday things more challenging. So working in tandem with the findings of at least 10 of these studies, the dissertation included 12 original studies. Now, out of these 12 original studies, 10 studies did highlight the theme of support and connection as a valid point. And it highlighted the crucial role of support and connection in mitigating the impact of stigma on mental health services. The second point, which is empowerment and advocacy. 7 of the studies did emphasize this theme in their results. Empowerment and advocacy can be seen as a means of challenging the impact of stigma and empowering individuals who have mental illnesses to share their experiences, either through art or IT or other forms of support or religion. Moving on, another point was education or learning or knowledge. And 7 of the 12 studies did highlight this as a common theme as well. It emphasizes the potential of educational interventions in addressing negative labels and promoting understanding and empathy among service users, caregivers, the general public, and various other stakeholders. The fourth theme was integration with other types of support, and 4 out of the 12 studies did highlight integration as a common theme. The integration of various sorts of care or other types of support could be critical and integral in overcoming stigmatization views and building a sense of belonging among these individuals. The 5th point was awareness, which could be self-awareness, public awareness, or media awareness. And 5 of the studies did highlight this point. And they did explain that increased awareness can assist those who are affected to counteract negative perceptions and minimize stigma experienced by them. The 6th point is willpower and self-reliance. And 3 of the authors did highlight that individuals facing stigma might take a proactive approach to their healing or their recovery or on their journey of stigma or mental health illness journey through strong will, developing a strong sense of will, and through personal resolve as well. Another point is the sense of identity, and 4 of the studies did highlight this as a common goal, as a common theme. They discussed the influence of identity, which would include self-perception, cultural origins, on experiences of mental illness and recovery, and that maintaining a positive sense of identity is seen as critical. These were all results that included the opinions of the service users who were involved in these primary research studies. The 8th point was the benefit and convenience of IT, and 3 of the studies demonstrated how technology can give benefits and convenience to people suffering from mental illness, thereby mitigating the impact of stigma and, in a sense, empowering these affected individuals to take an active role in their own recovery. It was like, in a sense, giving them back their control and their sense of ownership of whatever was happening with them. The ninth point was policy change, which was a common theme among two of the studies. And policy changes were identified as a critical factor in altering societal attitudes because typically social interactions and labels that are ascribed to individuals who are undergoing mental illness do affect their identity and behavior. So it was encouraged that policy reforms would go a long way, legislative measures, that is, in promoting awareness, education, and destigmatization activities. The last point, the 10th theme, was religion, which was a common pattern in two of the studies. And using the labeling theory, it was used to explore how religious beliefs can affect one's experiences of mental illness, and that faith and spirituality could be recognized as sources of support and empowerment, but they may also act as potential barriers to seeking professional mental health care. Moving on, briefly discussing the implications of these findings as well as the recommendations. Acknowledging the impact, I began by acknowledging the impact of the labeling theory, because in discussing the implication, in the discussion of the findings, it had to be in relation to theory, policy. For the sake of this dissertation, UK policies, and for the sake of this dissertation as well, health and social care practice in the UK. So the use of labeling theory was justified because of its comprehensive understanding of mental illness stigma. The strategies, like the themes that we identified, the 10 themes that were identified, all emphasized and aligned with the labeling theory. In looking at the complexities of stigma, we have the initial two main categories, which is public stigma and self-stigma, all of which can affect the older individual's well-being. Now, when you bring in age-based stereotypes, they further contribute to ageism and internal stigma, further influencing the societal perception of the elderly or towards the elderly. While further discussing the findings, global perspectives had to be considered. And in looking at global perspectives, one had to consider the current economic climate as well, because in order to help us gain a deeper understanding of what we mean by global perspectives in relation to stigma and the elderly, I, in a study 2022, did explain that global organizations frequently do ignore the mental health of older adults, and it is often apparent in the absence of policy and strategies that pertain exclusively to the elderly. In addition, Cummings in his 2018 study did say that the UK's health and social care sector is grossly underfunded. And so because of austerity, there are a lot of challenges. So whilst a lot of the discussions are positive strategies and contributions, as acknowledged by all of these authors, Cummings did say that the UK's current economic climate or environment would probably not allow for a lot of these strategies to be implemented. The policy implications include consideration of economic factors, which I recently just mentioned, like neoliberalism, because the UK is a neoliberal system of government, which would mean that it encourages free markets and individualism. So because of the free market state, a lot of budgets are often being cut short, and some of these could spill over into the health and social care sector. So all of these are what policy stakeholders and decision makers consider before allocating resources strictly dedicated to the elderly. So arts-based approaches, media literacy and responsible reporting, technology integration, patient-centered care, cultural competence, psychoeducation and education strategies, intersectionality and inclusivity, as well as policy reforms, were all recommendations from for all of the 12 studies. Every single one of them talked about their recommendations, and in discussing them, they were critically evaluated in relation to the present UK economy for the purpose of this dissertation essay. So in conclusion, it was seen that whilst there is an increase in advocacy for a multifaceted approach involving theoretical policy, UK policy, for instance, and practical considerations in the field of social healthcare to effectively address mental health stigma. However, the challenges posed by economic constraints in this country, for instance, and societal perceptions, there is more emphasis to encourage more evidence-based research. It is suggested that as long as evidence-based research, or if there is an increase in evidence-based research strictly pertaining to the elderly, there is an increase in all of that, it could create or increase the inclusive approach, either by adapting or working on present strategies. It would encourage research or strategy strictly tailored to the elderly. And that brings me to the summary and questions, comments, and concerns. Whilst before I entertain questions and comments, I would like to extend my heartfelt gratitude to Zainab Blauer, who is my dissertation supervisor. She pushed me to excellence, and she never stopped correcting me. She kept encouraging me to push. She pushed me beyond my limits, and I'm absolutely grateful to her that I have a distinction today and that I am on my path to becoming a published author with my dissertation work. It's all thanks to Zena. Thank you all.
Thank you, Funmi. That's great. Before we go into any questions, just pass on our heartfelt condolences from myself and colleagues within the school about the loss of your father. I think he'd have been incredibly proud of you to come and do this today. So,
Thank you.
Okay, we are a little bit pushed for time, but I'm just going to throw it out there. Has anybody got? Got time for one question? Has anybody got a question for Funmi? I'll take that as a no. I'm going to ask you something for me if I have something. Do you think that attitudes are changing then around mental health, particularly in older adults? So you mentioned public perception and you mentioned self-perception. Do you think those attitudes are changing in recent times?
Yes, I do believe those attitudes are changing, and I went into it more clearly in my dissertation. Yes, those attitudes are changing.
Okay, for better or for worse?
For better, they are changing, yes.
Okay, well, we do have another question as well. So I see there's a hand raised. If you've got your hand raised, it's Imadi Unakabog. Sorry, I can't pronounce that. You can come on and speak if you'd like to.
Hey, hello, Funmi.
Hi.
I enjoyed the section so well because it's
Thank you.
something of interest to a lot of people. So basically, I noticed that you mentioned that the topic about elderly people have not really been discussed, or there are few articles relating to elderly people. And I noticed that you made use of population and exposure and outcome. Since you said it's actually a primary study, why didn't you just go into doing an intervention instead of an exposure? Like having to do like proper recruiting participants in your research and all that.
Oh, okay. My research dissertation was a literature review, not a primary, not a literature review means that you review primary articles of various authors in relation to your subject matter. So my work was a comprehensive literature review. That's why. Did I answer the question?
Yes, thanks. Yes.
Okay.
Great. Funmi, thank you ever so much. So we're going to move on to our next speaker. Funmi, if you can stop sharing your screen, please. And Moses, if you want to get yourself set up while I introduce you, that would be great. So our next speaker is Moses Olwenyi, another soon-to-be graduate from our MSc in Health and Social Care. Moses has over 15 years experience in primary healthcare, project management and programme design. He's currently working with a West Midlands-based private social care provider as an operations manager overseeing service delivery, compliance and strategic planning. Moses has previously worked in the relief and development sector in Uganda in various roles as a business development manager with WaterAid, a programme specialist with Mothers to Mothers, a programme manager and projects manager with other various companies too. He's interested in global health and international development and now holds an MSc in Health and Social Care from the university. He also has a Bachelor of Medicine and Surgery. Moses aspires to be a lead a career in health and social care policy alongside establishing a network of private healthcare providers. Moses, if you're ready, over to you.
Yeah, thank you, Dr. Chris Kite. Thank you so much for the invitation to participate in this discussion, and I'm delighted to be joining the Wolverhampton family once again to share some of our experiences and findings in our recent dissertation process. My presentation in the next few minutes will cover the exploration of the COVID-19 vaccine hesitancy among UK ethnic minority health workers. And this is a systematic review that was done as part of the demonstration of the learning outcomes for the Master in Science in Health and Social Care that I did finalize most recently. My slides are stuck. Yes. Can you see them move your side?
Yeah, they're moving. Yeah.
The presentation is pretty basic, and I'll tackle those areas highlighted, providing an overview and background, methods, and results with the discussion at the end. We shall have a few minutes for some questions, so bear with me. The title of my dissertation was the COVID-19 Vaccine Hesitancy and Uptake Among Black, Asian, and Ethnic Minorities Health Workers in the UK. And as I said earlier, it was a systematic review that was done in fulfillment of the requirements of the MSc Health and Social Care. I started this work sometime in April 2023 with ethical approval, and finalized that by sometime in early July for submission in September, in August of the same year. So, what is the issue here? We all are aware that COVID has been perhaps the most significant global experience we've had over the last 3 years, and it's certainly responsible for over 3 million deaths and still counting. Just in the UK alone, we just had over 150,000 deaths that were reported directly attributable to COVID-19 between 2020 and 2023. And it's been noted that, unfortunately, Black, Asian, and other minority groups were disproportionately more affected by this global problem, with the mortality rate being much higher than that was observed among its white counterparts in the UK. And for the Burma healthcare workers specifically, as a subgroup, we noted that over 60% of the mortalities reported in this area was attributable to was amongst Black, Asian, and other minority group health workers, and this was in the early stage of the pandemic, sometime in 2020. NHS data shows that the Burma group constitutes a significant portion of the health force workforce in the UK, especially for the patient-facing and roles, especially those that will see clients on a day-to-day basis. When it comes to the higher levels and higher cadres, we find less of the minorities represented in this area. Studies for long have demonstrated the efficacy of immunization as one of the most versatile public health tools to manage infectious diseases globally, and it's responsible for the ability of our systems to have actually declared many countries polio-free, and therefore it continues to be one single repertoire that has been applied in conditions including that, such as COVID. However, COVID, like some of the illnesses in the last decades, specifically measles, mumps, rubella, and of course now COVID, has experienced vaccine hesitancy, which is the reluctance here among an individual, groups of individuals to take up a vaccine, even if it's available. So it's not an issue of access now, it's an issue of whether somebody will take it when it's offered. And there are usually reasons that are shared or proposed by the individuals as to why they will not take a vaccine when it's available. And even if issues with respect to concerns are addressed, there will still be this reluctance to take on the vaccine. This behavior occurs in a spectrum, so it's not a very specific behavior as such. It varies from one end over the spectrum, where we find people who are more than happy to take up the vaccine, and these are not vaccine hesitant. And then it translates to the other end of the spectrum, where we find those individuals who will not take up a vaccine and will exhibit total refusal of the vaccine, even if they are offered this. So what we term as hesitancy pretty much is that group that is hesitant to take the vaccine now, but may consider taking it later, or will not take the vaccine at any time, irrespective of the reasons. And we know that this behavior, demonstrated by other authorities, has a limit on herd immunity, which is the proportion of the community that needs to be vaccinated for a vaccine to be effective. And this is normally pretty much around 80% for most infectious diseases. And once people don't take up the vaccine, then that threshold falls below that, and we're not able to achieve immunity in a population prevention program like that. Vaccine hesitancy in the UK, for example, among health workers, in previous studies was demonstrated to range from about 1 in 3 to as high as 2 out of every 3 individuals. And the reasons given for hesitancy here have always been issues around the concerns around efficacy, trust, issues around culture, religion, and the experience of racism. Yes, so in terms of gaps, these studies that have been done previously seem not to have adequately addressed vaccine-specific hesitancy. Hesitancy is looked at as perhaps something that is exhibited towards vaccines in general, whereas there might be nuances within people's behavior where they might be preference for one thing or the other, because not all vaccines are the same in terms of how they work and what they're made of. There has been, of course, limited information in vaccine trends from the start of the pandemic to date. We are not sure whether there have been any changes as the pandemic has evolved, as people's knowledge has changed, as information becomes more widely available, or as confirmation of the presence of short-term side effects is shared amongst the scientific community. So we would like to know if there have been any changes to that particular aspect. We also note that in general, there has been a reduction in mortality, hospitalization rates, and morbidity due to COVID. And people's behavior, testing behavior particularly, sometimes driven by fear of death, fear of complications, may make people either more likely to take up a vaccine, or if there is no fear of death, then people are likely to even be more reluctant to undertake taking a therapeutic agent once offered, including a vaccine in this case. The role of religion, culture, and the experience of discrimination amongst VAME groups wasn't clearly explored in the studies. There was a reference to some, but it wasn't explicit enough for one to understand if indeed culture and religion has any bearing with respect to vaccine hesitancy amongst the VAME healthcare workers. So with respect to that, these were the research questions that we set out to address: the extent of vaccine hesitance amongst the VAME healthcare workers compared to white colleagues, how significant are these cultural beliefs and religious practices in shaping vaccine hesitance amongst VAME healthcare workers, and then to what degree does the experience of discrimination and racism contribute to vaccine hesitancy. And then lastly, the perception of vaccine safety and efficacy. How does that impact on vaccine hesitancy among this particular group of individuals? So with that in mind, the study was designed as a systematic review, which is, like my previous speaker has said, this is secondary research and set out to review existing literature to be able to identify, put together, collect, analyze, and present the findings from these primary studies on vaccine hesitancy behavior in VAME healthcare workers in the UK. And it followed the PRISMA guidelines, which is the guideline that sets the procedure for undertaking a systematic review to provide a standardized way of reporting on systematic reviews and analysis. And this involved, in my case, the search of relevant literature as per SAT terms derived from my study question and a topic, and involved search of a similar Medline, social index, and a few of the listed databases. And these terms, like I said earlier on, are derived from the research question itself, and combination of Boolean indicators and terms were used to challenge these databases and identify research articles that met these specific terms. And we did have clear guidelines in terms of eligibility criteria, with a focus on primary peer-reviewed articles in English, UK focused, published between 2023, being considered in this case. Anything else that was secondary research, such as commentaries or other systematic reviews, were not considered for this work. And the studies that have been identified were taken through a process of review. And this review started from, first of all references were identified and exported to Zetero, which was my reference management software. I took out the duplicates. Out of that, I went ahead to screen the data through title, abstract, and full text. The articles that had been identified meeting this criteria, which were 10 in number, were extracted using standard extraction form based on the Cochrane handbook. Data quality was appraised using a mixed methods appraisal tool. This is what I selected, given the fact that it would allow me to work with both the different study designs that I came across, that is a mixture of quantitative, qualitative, and mixed studies, rather than doing the process separately for each quality appraisal tool for a specific design. I had one tool to inform the entire process for all the studies I was able to extract. And I analyzed this data using two processes. Pretty much, this was a narrative synthesis, which is using texture, language, and information to bring together findings from different research. And this, in this case, was appropriate given the variations in methodologies and study designs, allowing me to get together and make a way of pulling and grouping this work in a way which could be used to analyze and compare across the board. Obviously, meta-analysis was possible, just like I said, a mixture of apples and oranges. Here we undertook the narrative synthesis and a thematic analysis of key things identified from the literature was written out. That is a screenshot of the Prisma flowchart. As you can see, there were just over 170 articles at the start. I did go down the line, taking out duplicates, removing those that were not eligible as per the eligibility criteria. And ultimately, I stayed with about 14 texts that were used for full text analysis, where I did drop 4 because of non-conformity due to commentary, wrong intervention, and another was based on pretty much healthcare workers' views on mandatory vaccination rather than the topic of interest. From these studies, the findings that I found that are key that I would like to share pretty much is that indeed vaccine hesitancy is correlated with factors such as ethnicity, age, gender, and job role. And this vaccine hesitancy varies. It is not so closely pulled together. It varied from a low range of just over 6% to as high as 35% amongst healthcare workers in general. And this is both white and other ethnic groups, including the family group in question. However, in these results, we do note that primary healthcare workers had significantly higher rates of vaccine hesitancy compared to white counterparts. In one study, it was as high as 45. In another, it was pretty much close to 48. When you compare to the white counterparts, a lot of the studies gave the highest record for vaccine hesitance amongst whites to be just about 30%. And when you probe down further, it's interesting that even amongst the Bami group, it's skewed towards a certain group, which is the Black Caribbeans. Black Caribbeans were 3 times more likely to be vaccine hesitant than whites. And when you compare that amongst other Blacks, Black Africans, for example, were just 2 times as vaccine hesitant as white counterparts.
Sorry to interject, Moses. Can I just ask you to start bringing it to a close, please? Time's passed. Think about summarising. Sorry to cut you off.
Okay, thank you. Elderly persons were more significantly likely to be vaccine hesitant. Females were more than 1.5 times more likely to be vaccine hesitant. And last but not least, the lower cadres were more likely to be hesitant compared to the more senior ones. In terms of the major reasons, the main reason given to vaccine hesitance was side effects and adverse events, with nearly 64% of respondents in one study indicating that side effects was a major issue of concern for vaccine hesitancy. The concern around the fear of side effects was many times associated with the pace of vaccine development, changes in vaccine guidance throughout the pandemic, and some cases, individual concerns on vaccine-specific side effects. In terms of the discussions, yes, as these studies all demonstrate, ethnicity is a key factor, and Black people, especially Caribbean people, are significantly more vaccine hesitant than other groups of people. There was allusion to the experience of racism and discrimination, especially amongst the Caribbeans, being a driver or a motivator for their vaccine hesitancy and disbelief when it comes to science or vaccine research. And interestingly, religion and culture doesn't seem to be a major factor here. So the findings were contradictory. there didn't seem to be a clear indication that religion and culture are primarily major drivers for vaccine hesitancy. And yes, inequalities and experience of deprivation seem to be fairly possible phenomenon that may precipitate vaccine hesitancy among this group of people. Yeah, I will like to just offer the recommendations indicated in there, but pretty much it's pretty much about the need to have more longitudinal research studies that track changes in vaccine behavior over time, rather than the cross-sectional study designs, and having a more standardized approach to measuring vaccine hesitancy may perhaps provide us with a more accurate, perhaps more user-friendly information, given the differences in measurements across the different studies. And it's difficult to have correlations and comparisons when you look at all of that stuff put together. Yeah, so others, of course, would include the more vaccine-specific vaccine hesitancy, other than looking at vaccine hesitancy as a general phenomenon. We look at whether there is particular concern about particular vaccines or particular ingredients, and then working towards addressing those concerns, than having a one-size-fits-all approach to doing things. And of course, responding to the concerns of primary healthcare workers, involving them in study designs, in research such as that, but also in research that is towards generating effective therapies for vaccine, for vaccination programs. Yeah. Thank you. I won't have done all that without the support of my team. I need to acknowledge these individuals for their support. And yeah, thank you so much, my colleagues as well. It was great working with you, and I look forward to working with all of us as the future opens up opportunities for collaboration. Thank you.
Thank you, Moses. So really interesting talk, and you know, really important project. I think everyone will agree. We are very pushed for time, but we will make time at the end so that we can listen to Rabi, our final speaker. I am just going to throw it open if anybody's got a question for Moses. Please just unmute yourself and come on and ask it. If there are no questions, then I am going to move on just because of the timings. Any questions? Speak now or forever hold your peace. Or just email Moses afterwards. Okay, Moses, if you want to stop sharing, thank you ever so much. Really good project, really interesting topic. Rabi, if I'm hoping you've managed to resolve your issue around share screen. Are you able to share your slides, please, Rabi, while I introduce you? Do you have the share button, Rabi?
I do have the share button.
Okay. So I'm going to introduce you if you want to try and work through sharing your screen while I do that, and then we'll look to make a prompt start.
This is crazy.
Okay, so our final speaker is Rabi Zabadi, who was educated in Lagos in Nigeria, gaining admission in 2005 to study medicine and surgery. She graduated as a medical doctor, and in 2017 obtained her first master's in reproductive health. She wrote a thesis titled Knowledge, Attitude and Perception of the Use of Contraceptive on Adolescents in Jaji Community. Rabi has worked at the University Teaching Hospital before going on to work as a reproductive health specialist GP at the Armed Forces Command and Staff College in Jaji Medical Center and with the UN Support Office in Somalia. She came to the University of Wolverhampton in 2022, successfully completing her Masters in Public Health this year. How are you doing, Rabi?
Fine, thank you. But I am having a problem sharing. I'm still having the problem sharing my screen.
Okay, can you email me your slides very quickly and I will share the screen for you?
Okay. I'm freaking out.
Don't panic. It's fine.
Can't even find it.
So just while we're waiting for that, if anybody did have any thoughts or comments for Moses or indeed for Funmi, she's still with us, then let's use this time to ask those questions.
Wow.
Moses, I'm going to ask you a question while we're just waiting for Rabi to sort of slides. I'm sorry to pull you back into the spotlight. I just wanted to ask, are you still there, Moses, first of all?
I'm still here, sorry.
Yeah.
I was on mute.
So, I mean, really interesting findings about the vaccine hesitancy and the COVID-19 vaccination. Do you know if there's a similar hesitancy amongst other vaccination programs? I mean, I'm thinking here about, the annual flu vaccination, for example, but is there a reluctance to vaccinate children with MMR and, other vaccination programs, or does it just seem to be unique to COVID-19?
Yeah, that's an excellent question, Dr. Chris. Thank you so much. Yes, vaccine hesitancy is not isolated to COVID-19. Indeed, it's been highlighted for as long as vaccines have been available in the world. However, I think significantly speaking, vaccine hesitancy did increase during the time when MMR issues were first raised more than a decade and a half ago, 2 decades ago, in the early 2000s, when there were concerns over MMR and autism. Even though research was eventually done and this issue was debunked, it didn't quite leave the mainstream, unfortunately, and it has continued to affect views towards MMR vaccine, especially in Europe. When one looks at similar vaccines in the global south, in Africa, for example, there are very low levels of vaccine hesitancy among these populations. In fact, the biggest barrier to vaccine uptake is indeed uptake. We do have measles uptake, for example, in a country like Uganda is nearly about 80%, which demonstrates a very high level of uptake. And the 20% who haven't taken up the vaccines normally due to issues around access and communities that are just inaccessible. When it comes to the vaccines around seasonal flu uptake incidentally is very high. The uptake is high among people who are actually vulnerable, who have experienced the challenges of pneumonia in that age group, and therefore this uptake is relatively higher than you find. However, reasons for non-uptake are generally similar, but it's much less compared to COVID-19.
Okay, really interesting. And obviously, you spoke quite a lot about healthcare workers there. Do you think that hesitancy amongst healthcare workers is impacting upon their patients and influencing attitudes towards vaccination in general?
Yes, indeed. In fact, studies, one of the studies did indicate that patients have a lot of trust and faith in healthcare workers, and the decision to take medication in many cases is hinged upon the advice of their GP or their doctor, and they have a lot of trust and faith in the views, medical and otherwise, of such healthcare workers, and therefore correlating with this, it's been suggested that perhaps high vaccine hesitancy rates among its healthcare workers will result in corresponding low uptake in the general population because of the sharing of these concerns, fears, and feedback. And indeed, a lot of the misconceptions and conspiracies that we did see on social media were for the general population who are driven by people from a healthcare background who did indicate that they had concerns about the vaccines.
Okay, that's great. Thank you ever so much. I've just received something from
I
Rabi.
think that's wrong. That's a wrong folder.
I've just had a look through, and it's not the right one.
Oh God, I don't know what's going on.
I'm just going to share my screen.
Let me start by apologizing. And I'm really conscious of the time, so I will rush up.
Well, like I say, it's been recorded, Rabi.
Okay.
So if you just take your time, and if people need to leave, they can catch it afterwards. I think there are a lot of colleagues who are interested in your talk specifically. So I'll obviously control your slides. If you just let me know when you're ready,
Yes.
just say change, and I'll move the slide for you. Okay.
Thank you so much.
Good luck.
You, everyone. I apologize once again for the delay. And I'd like to thank Chris for giving me this opportunity. I would also like to thank Jennifer. So next slide, please. My topic is exploring the experience of international students' journey to study in the UK, a case study of public health postgraduate students in the University of Wolverhampton. Next, please. It is my outline will be on this listings. So background research, questions, and all this. Next, please. It is not news that migration from developing to developed countries are on the rise. And as of 2022, there was almost 680,000 international students that came into the UK studying at undergraduate and postgraduate level. Now, half of this number were strictly postgraduate students from the non-European countries. And from 2017 to 2021, there was a 13.8% rise from 197,000 to 338,000. Next, please. Now, despite the fact that the UK gives a wonderful learning experience to postgraduate students, it is not news that international students face difficulties when they come into the UK. And we're talking about difficulties such as the marked difference in education tradition from that has to do with the approaches to study and research. We know there are accommodation struggles, especially with to students with families. There are migration related issues, cultural shocks, and whatnot. And while most of these people settle with little or no complications, there are some students that have experiences that are specifically due to the level of preparedness that they encountered from their home country. And when I mean level of preparedness, some has to do with the level of information they received, or the amount of information, whether true or false, that influenced their coming into the UK to study. And another very important aspect has to do with finance, from proof of funds, or those who borrowed money thinking they were probably coming into the UK to pick money on the floor or whatnot. Next, please. Now, the rationale behind my study is centered around the numerous challenges foreign students are faced with despite having adequate preparation and planning to come into the UK to study. It's against this backdrop that my study explored ways of improving the settling integration of international students and its environs for enhanced learning and living experience. University of Wolverhampton has over 2,500 foreign students with over 130 nations, represented in its campus. Campus, next, please. And the reason why people pick the University of Wolverhampton is not far-fetched. It has a high employability rate. It has a good academic ranking. The university is affordable compared to other universities in the UK. Its location is in the Midlands, centrally placed, where you could access so many parts of the UK. And of course, the university is a hospitable university. Now, the university, it's worthy of note that the university offers scholarships that extend to international students. And this, one of them is the Alan Turing or scholarship, popularly known as the Hardship Scholarship. It also offers mental and academic support to international students. The university also enables students to pay their school fees in parts, understanding that students are going through hard times, or they probably have, other things to do with money. There are job placements too in jobs board that students could benefit from. However, international students have been shown to have been restricted. For example, student loans are not extended, to them. And then there are specific jobs that, specific to people holding, say, British passports and all that, international students may not benefit from, amongst other things. Next, please. Next, please. My research is aimed at identifying real-time challenges related to migrant students, particularly University of Wolverhampton MPH students, with the aim of proffering solutions and with the hopes that this solution would give them an uneventful encounter moving forward. My research questions was to know the relationship between pre-departure plans and post-arrival experience of MPH students in the University of Wolverhampton. Also to know how the UK and University of Wolverhampton plan for education-related exports and international education activity in relation to students' pre-departure plan and post-arrival experience. The third one is to know the measures that can be adopted to improve the pre-departure plan, which will boost national education activities for enhanced post-arrival experience in the University of Wolverhampton. Next, please. My literature review basically discussed the major concepts in the study. It conceptualized the two major variables and established a relationship between them. Now, Brown 2019, a study conducted by Brown 2019 suggests that pre-departure plans should primarily focus on practical matters, such as housing arrangements, transportation, and basic lifelong essentials. However, Anderson said that pre-departure plans places a strong emphasis on mental health support. Therefore, it recognized the unique challenges faced by international students, and it should be adjusted to a new education. It should recognize that international students face unique challenges, and then should bring adjusting solutions that would probably help them settle better. Anderson was referring to issues like counseling and then coping strategies that will help international students. The next, please. There's also a study conducted by Lilliman and Bennett that clearly explains, this one talks about the experience now, that academic institution may promote a pleasant experience for international students with planning, support, understanding, and thereby turning their negative experience to positive ones. However, what this study failed to show is how the city itself, where these international students will be coming to reside or schooling, will have the plans, how they've made plans and support to help the government to accommodate them, especially married students and their dependents, through collaboration with property owners to help them settle faster. I talked about education-related exports. It's not news that when international students come into a foreign country, first and foremost, they are billed differently. And this money they pay serves as a form of revenue to the country and maybe even the city where they stay. So this study didn't talk about how maybe that revenue, could help people settle into the city fast. Because if I come into a city now, for example, I should be able to rent a house and buy stuff and make business owners there, gain profit. So yeah, that's what I was just trying to say here. So next slide, please. So according to Smith, students who have positive pre-departure, this is now talking about the relationship between them. So students who have positive pre-departure experience, such as comprehensive orientation programs and adequate information about destination country, that they are believed to have a better post-arrival experience. But Johnson highlights the importance of post-arrival support systems, such as mentorship program and effective social integration. So Johnson is saying that it's not just enough that if you have a pre-departure experience, that you have a good positive one, that you have to have other things to support, such as mentorship and social integration. That also will boost your post-arrival experience. Now, furthermore, that a middle ground perspective suggests that the relationship between pre-departure experience and post-arrival, pre-departure plans and post-arrival experience is a complex and a multifaceted one. Next, please. Now, a theory was adopted for my study, and I used the theory of met expectation. What is this theory? It simply suggests that individuals compare their initial expectations with their actual experience, influencing their overall satisfaction and perception of an event or situation. Next, please. So my research design was a qualitative study using the phenomenology approach. Now, phenomenology also emphasized the exploration of lived experiences and how individuals would perceive and interpret the world around them. Now, this particular this approach has relevance and impact in the pre-departure and post-arrival experience of international students, in that it prioritizes individuals' subjective experiences, their emotion, and also provide an understanding for their decision-making as well as their lived experiences. Next, please. My sampling strategy is non-probability sampling method, and the proposed type was homogeneous purposive sampling technique. Now, this was chosen bearing in mind reliability, consistency, looking at the sample size and the usefulness of the proposed data, and because the research topic is peculiar to a specific sample population who have the same feature in common, and that's what this non-probability homogeneous sampling takes into cognizance. Now, next, please, next. So my sample size, I looked for 10 participants, 5 single, 5 married. The inclusion criteria are consenting students, they're international students that gained their visas from their home countries, and they were students who gained admission in September 2022. The exclusion criteria are non-consenting students and students from European Union. The reason why these people are excluded is because the visa criteria, or the criteria to come into the UK to study for European people in European countries, is different from that of those from non-European country. And this sample needs to work with people from the same sample characteristics in order to avoid bias. Next, please. My data collection took a maximum of 4 weeks. A framework was used, which is the PEO, that's population, which is international students. The E is for exposure, and that's their migration journey. And then the outcome is their lived experience. I used narrative analysis to develop a core narrative. Next, please. Next, please. Next. Yes, there was ethical consideration. I took consent. I assured them of their confidentiality, told them about the risk involved. I explained the process to them, and then I explained to them how their data will be protected. Next, please. So now, based on the results, my result was based on objectives and interview questions of the paper, on my interview questions and paper. It was measured by reporting their experiences and attributed reasons for relocation. This was done in 5 sections. First one was their demography, and it showed people from various countries representing there, and their occupation and whatnot. So the next section interviewed their pre-departure experience after gaining admission. The next one talked about their post-arrival experience, talked about ordeals from the airport and upon arriving into the city. The next one talked about the lived experiences. We looked at their lifestyle, the weather, guidelines, diet, their coping strategies, and they offered recommendations and areas of improvement that will help them. Next, please. My key findings is that each participant had a unique and subjective preparatory, settling, academic, and social encounter. Now, inadequate job opportunities, accommodation, and the restriction on working hours impacted largely on these students' mental health. And it was attributed to their respective post-arrival experience, as well as policies and guidelines that was set by the UK and the University of Wolverhampton for these students. Talking about, especially for the married people, they complained about the fact that, there was a no children policy in school, which is understandable. However, they also complained that there wasn't availability of crèche that could help them drop their children in the school. Now, most of the participants also agreed that there was a direct and indirect correlation between their pre-departure plans and their lived experiences. Next, please. Now, I had a notable discovery. 90% of the married participants had 1 or 2 complaints. I'm emphasizing on the married participants because the single ones, basically their problem was on loneliness and maybe socialization. They didn't even have problems with accommodation and all, because there were private accommodations and the school accommodations and whatnot. Now, this particular married participant didn't have any issue. And that's because her husband or her partner came from their home country with a work visa, and it made their settling in seamless. Only one. So I thought it was worthy to note. She had a positive pre-departure, post-arrival experience because her husband had a work visa to come into the UK. Participants who made academic pre-departure plans had a positive learning and rewarding experience compared to others who did not. That is, those who joined the online library classes and the English writing classes while they were in their home countries before they came into the university had a wonderful and spectacular result in their first semester. And that's because while others were trying to cope with how to write, and at the same time, the subjects that were ongoing, these people had already gone way ahead to learn about academic writing. So it was easy. So they had a spectacular academic experience in their first semester. Most participants, despite being highly educated, faced tremendous difficulties in securing graduate level part-time employment, especially the disabled. Now, this disabled candidate has been applying for a job, nothing. Some felt that they were, despite their academic performances, that they didn't have jobs that were like, they didn't have research assistant jobs that was in line with their academic pursuits. Next, please. The participants' recommendations is that they feel that tax exemption should be extended to post-study period to allow them time to settle. The disabled students complained of inclusivity. The participants also requested that the university should liaise with alumni of the school who are into property management to provide accommodation, especially for married students, or references. They also said that they would like the school to limit the number of intakes to be able to give them a better academic experience. Next, please. This is my conclusion. The study aimed to appraise pre-departure plans and their effect on post-arrival experience regarding migrant postgraduate students in the university and to establish a relationship between them. I used the phenomenology approach with a focus to examine how individuals' perspectives were influenced by their realities and their lived experiences. Limitations were faced in this study. It was supposed to be a focus study of 20 people, but people wanted to give their personal experience. They wanted to make it private. I couldn't gather people in the same room. And so I had to make it a one-on-one interview. Thank you so much. And I'm really sorry. Once again, thank you.
Thanks, Rabi. No need to apologise. I'm pleased to see that the vast majority of people have stayed around, and happy to say that it was worth the wait. So well done. I'm just going to throw this open. Does anybody have any questions that they would like to ask Rabi? Yes, straight away with a question here.
Hi. I really enjoyed your section, but I just have a few questions. I just wanted to know, the students that were recruited, the international students, were they based on a particular continent or it was mixed? Because you spoke about excluding European students. Was it just African students or Asian students, because most of those immigration rules goes down to others aside the European students. So the number of students, the 10 students that were selected, did you pick it just from Africa? Then the disabled participant, how many were they that made that decision that there was no inclusive, they were not included, or they were not recognized at some extent during their study? I just wanted to know the number of disabled students, and what continent did you focus on in your when you were recruiting?
Thank you so much for this question. To be very honest with you, I struggled with my slides because that information, I struggled between putting it and removing it. Now, in my demographics, there were Asians in it, and in the class, I skipped a slide, it was there. So I did a survey in the class to know the people who were represented in the class. And it may interest you to know that over 90% of the class were Africans, of which about 80-something% were Nigerians. But still, out of the 10 participants, Nigerians were 5. And I felt that was even fair enough because they made up the vast majority of the class. The remaining 5, we had Asians, about, I think 3 of them. And then we had Asians, there were 2 of them. And the remaining were from other countries, Kenya, Uganda, and I can't remember the last country, but Nigerians were just 5. So the disabled participant was 1 person. That person made 10%, and that's the only disabled person in that class. So I had to make sure that I included that person so that I could also hear from their perspective. And if time had permitted, it was also part of the limitation of my study that this kind of topic should have been extended, it should have been extended beyond the walls of public MPH students to be able to include or get more of their lived experiences. And that way I would have captured more. Thank you so much. That's a very...
Yeah, thank you, because I was also going to ask again, because since you concentrated on one part, because I actually feel like there are a lot of bias to some extent, because I feel anybody who would have heard this, especially those who are single students, would have felt biased, and including someone who didn't really have an experience when it comes to this immigration. Probably the person would have been replaced with another, because I feel she already had a good experience, so she's not really expressing the feelings of we who might probably be single students and all that. So
the disabled person?
Yeah, the married lady that had a positive experience.
No, she was just one. Out of all the married people, it was just her.
She was the only married person in the number.
No, she was the only married person. There are 5 married, 5 single. She was the only married person that had a positive experience. The only one.
Okay. Now I get it.
Yes. Yeah, that's why I had to single her study out.
Wow, that's great. Thank you very much for that question. Jane, I thought your hand was up. It still is up?
It is still up, yes, thank you. I was quite interested where you said that actually the people who had the positive experience were the ones who actually engaged with the activities before they got here. So I'd like to know, why did the students who didn't engage, was there a particular reason why they hadn't engaged? Because obviously you've clearly shown that, you know, the work that we're trying to do beforehand to acclimatise students and to integrate them so they kind of know a bit of what's going on really does work. So the ones who didn't do that, was there a reason why they didn't engage with the pre-getting here activities?
Thank you so much, Jane, for this wonderful question. There is a reason, there are reasons, and the reason was because they had less time to prepare for their travel. They had other things preoccupying them. So the last thing they were looking at was probably looking at the online academic ongoing classes, they had to source for money. They somewhere they had to travel. It had to do with their level of preparedness. They had other things that were troubling them. But these particular people who had this experience, they had prepared. They even came they even arrived in the UK way before the academic class started. So they had ample time. And to be very honest with you, in the demography, these people were sponsored students, people that were sponsored by their parents and their family. So I would assume they didn't even have, they didn't have to bother about looking for money and all that, but they had ample time to prepare. That was it for all of them. The ones that didn't engage complained about coming to the UK in a rushed mode, and they weren't settled.
Okay, so again, it would appear that regardless of where you're from, class definitely seems to make a difference. And if you're a widening participation student, then you appear to be disadvantaged. So that's really useful. Thank you.
Thank you.
Thank you, Jane. I'm very conscious of the time, but I'm just going to ask one question and then we will wrap up. So thanks again, Rabi. I think it's quite a pertinent one to end on. If you could give one message from your study to policymakers at the university to improve the experiences of our international students, one key message, what would that be?
Thank you so much, Chris. Even though I didn't even see this question coming, I would first start by saying that my interview was very emotional. If I could even, some cried, some were annoyed, were shouting on me, and I'm like, whoa, 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 I'm just doing my job. But they were very emotional. The married people really faced accommodation challenges. So, but compared to how seamless, I wish I could, compared to how seamless it was for the single people. I'm not married, but I knew that I got my accommodation from the comfort of my home. I just, called hitting points, checked, and it was all done. But for them, you see, having to live with people, coming far and all that, it was terrible. And I believe that the school should also find a way to, if you're admitting people with, well, there's no point now. The policy now doesn't allow master students to come in with their families. But, well, the disabled people, I think I would speak for them. I think that while we think we're doing a good job for them, we need to look into their side and include them more. I'm sorry, I'm saying more than one. The last one is that job opportunities should research assistant roles should be made more available to students rather than student union jobs. That's a very wonderful job. But some people came here because they had plans to go into PhD. So giving them research assistant jobs would really help. Thank you. I'm sorry.
That's great. Thank you very much, Rabi. Well, I know we've gone slightly over, but I'm going to draw this research seminar series to a close. Thank you all to our excellent speakers, Funmi, Moses and Rabi. I think you've done a very good job. You've obviously completed some very, very good research, and we look forward to seeing what you do in the future. Thanks, everybody.